Good morning and good afternoon. My name is Monica Pica and I'm with Sachs Healthcare, and I will be your technical producer for today's webinar. Firstly, on behalf of Philips and Sachs Communications, we want to thank all of the frontline workers in our audience for your commitment and passion in helping all of us through this very difficult time. We are truly indebted to all of you. I want to show the audience how you can send questions in throughout the webinar. Our speaker will try to answer as many questions at the end of the presentation as time permits. And before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's events will be available soon after the session. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. If you experience technical difficulties, please use the Tech Support tab, also located on the right side of your screen, and press Enter. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC or Command R if you're using a Mac. Please make sure you are not behind a firewall at your location, as this will prevent you from viewing this webinar. Our moderator today is Dr. Betsy George. Dr. George is currently a clinical nurse specialist at UPMC in Pittsburgh, Pennsylvania. Her academic positions include adjunct professor at the University of Pittsburgh, as well as serving as a faculty member at Waynesburg University. She is a reviewer for the Heart and Lung Journal, in addition to having published over 75 articles and abstracts in several peer-reviewed publications. Dr. George has presented at numerous international, national, and regional medical conferences on transplantation and pulmonary topics. Welcome.
Thank you, Monica, for that kind introduction. I have the pleasure of introducing our speaker for today. Our speaker is Greg Stiver. Greg Stiver is a colleague and friend of mine. Greg is a clinical educator at the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania. In this capacity, Greg trains respiratory therapy staff, medical students, nurses, and paramedics in all aspects of respiratory care at one of the highest acuity medical centers in the country. He's an adjunct instructor for the NIOSH spirometry. Greg is also a board member at the Indiana University of Pennsylvania School of Respiratory Care and the Community College of Allegheny County Program for Respiratory Care. He's the co-author of a recently published article in Chest on spirometry. He is the recipient of a leadership award from West Penn Hospital. At this time, I would like to say that our speaker has disclosed no conflict of interest related to this presentation. I'd like to share with you how you may obtain your continuing education credits. This educational activity is approved for 1 contact hour for nurses, respiratory therapists, and EMS professionals. A link to obtain credits will be available at the end of the webinar. As noted on this slide is the accreditation statement. Support for this educational activity has been approved and provided by Philips. At this time, I would like to turn the presentation over to Greg. Greg?
Thank you, Doctor. I'd like to thank everyone for everything you've done in this COVID pandemic. I find it a real pleasure to be part of healthcare at such trying times as we've been going through, and I commend you for everything you've done and your lives that you put at risk to make other people better. Dr. George, I do appreciate your kind words. It's been a pleasure for me to work with Dr. George for 16 to 17 years. She's a true professional, and she's someone that everybody should aspire to be. So today, we're going to talk about pulse oximetry, why it is a necessary tool in the COVID-19 pandemic. So with this, we have a few learning objectives we need to make sure we cover today. And what we're looking for is, with pulse oximetry, this non-invasive technology, I want to make sure you understand the mechanism of how pulse oximetry works. That's important to understand when there's limitations and when we may not be getting reliable data. So we want to make you understand what to look for to see if it looks reliable. And if it doesn't look reliable, give you troubleshooting techniques so that you can figure out whether you have good data or you need to move on to other means to check the patient's oxygen status. And of course, we will describe the advantages and disadvantages of various sensors, such as the finger, the nose, the ear, and the forehead. Now, everybody in the world knows about COVID-19, so I really don't need to explain much about it. But obviously, we all know that we have people that can have no symptoms. They walk around carrying it and transmitting the disease and have no clue that they have it. And it can progress to the point that it touches nearly every single organ system, unlike any disease that I've ever fought in 30 years of being in a hospital. And then you have the frequency, depth, and recovery that varies widely from patient to patient. So with that, you also have oxygen needs that vary. So you're going to have patients who are going to stay at home and never go on oxygen. There's other patients that are going to go on oxygen in their home. And of course, when we go into the hospital, we may have oxygen up to the 6 liters a minute, like they may have at home, sometimes more. But then in a hospital setting, we may go to a high flow nasal cannula where we provide flow rates up to 15 liters a minute. Now, when we first started the pandemic, the heated high flow systems, the ones that run at liter flows as high as 80 liters per minute, were off the table at our institution and throughout most of the country. But after a while, science figured out that this was still safe to do, and so it was put onto the table just like non-invasive ventilation was put onto the table. So we brought those technologies back. And of course, finally, a patient may progress to the point that they go on mechanical ventilation for weeks, months, before they either recover or they may pass away. So it's the range and depth of these symptoms is why pulse oximetry is a necessary tool throughout this pandemic. So there's a unique phenomenon in COVID-19, and that is patients who have oxygenation that is incompatible with life without dyspnea. And this is often referred to as happy hypoxia or silent hypoxemia. So let's take a look at a couple of cases that are similar to this. You've got a 64-year-old male. He tested positive. He's diagnosed with COVID-19. And while the patient is on oxygen, he's getting 6 liters a minute. He has a saturation of 68%. And arterial blood gas shows his PaO2 at 37 millimeters of mercury. But yet he consistently denied any difficulty with breathing. And upon exam, he was comfortable and not using any accessory muscles of respiration. And this gentleman had 6 comorbidities. So this is basically the patient that you hope doesn't get COVID because they're in that age of 65 plus and they have comorbidities. But this gentleman at this time was only on 6 liters a minute, but it's interesting that he's not showing any symptoms with his disease process. Now you have another gentleman, 74 years old. He tested positive. He's diagnosed with COVID-19. Now he's on a 15-liter non-rebreather with a saturation by pulse oximetry at 62%. His arterial blood gas was 34 millimeters of mercury. Again, he denied any difficulty with breathing. He was comfortable and no accessory muscle use and no comorbidities. Yet you have an oxygenation that should have been delivering symptoms to us to say what kind of critical state this patient is actually in. And yet they're walking around as if they don't necessarily even know they have something going on. There's some answers to these things. It could be the oxygen hemoglobin dissociation curve related to temperatures and such. But the reality is it surprises people when you come into an ED and you see somebody with this blood work, whether it's pulse oximetry or ABG, and yet they do not show the symptoms of hypoxia. So we all know the symptoms of hypoxia, but just as a review, restlessness, anxiety, course, tachycardia and tachypnea are early signs that we're going to see. The patient can have bradycardia. Late sign is that extreme restlessness. Of course, dyspnea that is severe is another sign of hypoxia. And yet those two previous cases, not one single sign was there. Now, in the young population in our pediatrics, you have feeding difficulties, inspiratory stridor, nasal flaring, expiratory grunting, or sternal retraction. So these are the things we should have seen on those two previous patients, but yet we did not. So when we want to check oxygen, the gold standard is an arterial blood gas. We have a direct measurement of oxygen by an arterial line or a stick. The value comes out of blood gas analyzers that are under strict regulation. So those devices have daily QCs performed. Every 6 months, they're going to have linearities and proficiencies that are done. There's money associated with all those things that we just talked about that the hospital has to absorb to provide those services. And then, of course, a blood gas lab has to be regulated by somebody. So every 2 or 3 years, you may have Joint Commission coming in, or you might have CAP, the College of American Pathologists, who come in to check to make sure that you're following all the rules you need to do to make sure the results that you put into that chart are accurate. Now, what are the negatives to a blood gas? Obviously, on a stick, it can be painful. Very few times in over 30 years have I had a patient say that they didn't feel a blood gas stick. They usually feel it to some degree and sometimes pretty intensely. If we have an art line, you have a possible infection source. So that's another negative outcome possibly for our patients. And then what about the fact that the results can take time to get? If you're lucky enough to have a blood gas analyzer in your ICU and it's across the room, you're going to get your results pretty quickly. If it happens to be going to a lab that's three floors down, well, that's going to take a little bit of time. And I've worked in hospitals where the lab is literally 3 blocks down the road and it gets tubed there, and you're not going to see the results for a half hour. So you don't have that continuously available oxygen readings, and that is the advantage of pulse oximetry. So with pulse oximetry, it is considered the 5th vital sign. Because it is the 5th vital sign, it's typically referred to as it must be reported. Well, that's an issue we're going to come back to a little bit later. Now, pulse oximetry is non-invasive. So just like any procedure that we do that's non-invasive, there are issues that can relate to the fact that it's not an exact direct measurement, but we're actually doing other things to come up with that data, and we'll talk about that. Now, the beauty of pulse oximetry is that the results are highly proficient. Typically, they're plus or minus 2%. Now, if you have a patient in motion, the results are going to be plus or minus 3%. And we'll talk about the causes for that. Have continuous oxygen saturations that are displayed, virtually pain-free. We'll talk about wounds later, where that could be an issue. Obviously, you don't have an infection risk since you're not breaking the skin. The question is, how does this technology work? So pulse oximetry works under the principle of photoplethysmography. So from my experience, it came to the first hospital that I worked at in the later 80s, and I actually thought it was like a newly invented technology at that time. Now, the first marketed pulse ox actually went into production in the mid-70s, but the technology was discovered back in the 20s and 30s. The interesting thing about that is utilizing this new technology that was discovered, they were able to determine that high altitude pilots were hypoxic. So when planes would veer off course, when planes would crash and he didn't understand the reason behind it, turns out hypoxia was one of the reasons. So this led to pressurized breathing apparatus and pressurized cabins in airplanes. So those of you that are in the room from respiratory, you might have heard of Dr. Bird. Dr. Bird was a pilot, but he also invented one of the first breathing apparatus for pilots so that they could fly at higher altitudes. Of course, that technology later then became the Bird Mark 7 that we've used for so many years, in respiratory care to provide drug aerosols and pressurized treatments to fix patients. Of course, we know pulse oximetry. You shoot a red light through their finger. But in reality, we're actually passing two lights through your finger or through your ear, whatever site we've chosen. One of those lights is a red light, one you can see, and the other is infrared that you cannot see. So oxygenated hemoglobin absorbs the infrared light. The red light's just going to pass right on through. Just the opposite occurs with the deoxygenated hemoglobin. Now you have the opposite wavelength absorbing the red light, absorbing the light. Now what happens with that process? It was sent out top of your finger and received by a receiver on the bottom. Those two beams of light go through, some gets diffused, some gets absorbed by oxygenated or deoxygenated hemoglobin. And what that pulse ox is actually doing, it's determining the color of the blood. It's determining the color of the arterial blood, and it's determining the color of the venous blood. And then it gives you a saturation of the hemoglobin with oxygen. Well, that's a story we're going to come back to as well later. Now, the color change between venous and arterial blood is very small. So in the absence of a strong pulse, your pulse ox signal is going to be challenged and it's going to come into question. So the one thing about pulse oximetry, you'll notice that the name is pulse oximetry. If it was just about oxygen, it would be oximetry. But pulse oximetry, the heart rate matters. The heart rate needs to correlate with your EKG heart rate, your actual heart rate. So typically what we'll say, and there's a little bit of variation from hospital to hospital, when a pulse ox and an EKG heart rate vary by greater than, say, 5 beats per minute, some say the variation is greater than 10%, that's when you need to think about questioning the saturation. Is the data that I'm seeing true or not? And the heart rate is one of the tools we're going to use to figure that out. So think about if the heart is beating faster than what the pulse ox sensor detects. Color gradient is going to be less, and so we're going to get artificial abnormal data. Also, as blood pools at a site, if I've got it on my finger, blood is pooling at that site. Oxygen consumption does not stop, and saturations will continue to drop lower. My slide is just stuck. Back, I guess all of a sudden it started moving for me. 1 second, please. Well, the computer decides to pitch back up here. Let me just continue where we're at. Back. For the technical difficulties here, but what we're going to talk about is the pulse ox waveform. So if we look at, talked about a correlation with heart rate. The next thing we need to talk about when we see something that we're questioning is that actual waveform of the pulse ox. So when my slide comes back to those waveforms again, we're going to talk about that normal signal. It's at the top. So the normal signal, some people will say, looks like an ocean wave that travels up and down. So what happens in that is that when your heart beats, just trying to get this thing to come back to where it should be. When we look at a normal pulse ox waveform, when blood comes into the finger from the beating heart or into the sensor from the beating heart, we're going to have a spike or change in the size of the finger, and that's when we're going to see our pulse ox waveform go up. Then as the blood drains back out, we're going to drop back down. We're going to see that low signal. What we want to see is a waveform that travels up and down. One slide without jumping again here. Now, think about a patient who's critically ill. And they're in a state where, as their body starts to shunt, try to send that blood back to the core, get vasoconstriction, and we can end up with poor perfusion or low perfusion at a site. And so we end up with a waveform at that time where your signal, now stays here, we'll see low perfusion there, second one down, where it's getting close to a flat line. Now think about that. That's not a lot of color gradient there. That's going to result in some issues, and we'll talk about these in more detail. There's also noise artifact. So if you see how choppy that signal is, that can be caused by a couple issues, and we'll talk about that. And then there's the motion artifact. So with motion artifact, now we have movement that we're trying to look at, changing the size of your finger. We're trying to look at that blood coming into your finger or into that sensor site. And now the hand is also moving, or the head is also moving. Now we're getting serial wave movement going on that allows us to not come up with an actual signal, quality signal. So let's talk about what causes those abnormal waveforms. So one of them is ambient light. So when we have a pulse ox, it is looking at light that's traveling in a set wavelength. And generally, it's going to be in the 50 to 60 hertz is what it's going to travel at. But other lights in the room, if they're traveling at wavelengths outside of that 50 or 60, are going to cause problems with our pulse oximeter, and we're going to end up having high saturations when actually the patient could be hypoxic. Now, the manufacturers, obviously, a long time ago figured out this issue and started shielding sensors to prevent this. So I'll show you an example of this a little bit later. So if you notice this noise artifact, remember that real choppy signal on the previous slide, you need to do something to try to shield it. Your pulse ox should be shielded, but there's still some light getting into that. So you can take that pulse ox sensor and literally just cover the hand, if it's on the finger, with a dark cloth. You can bury it under the sheets. Hopefully the patient will keep it there. Or another trick you can do is you can just open an alcohol gauze. Do whatever you want with the gauze. We don't want it. We want that foil-lined package. We want to slide it over the sensor, and now we've built our own light shield for a finger sensor. I've seen people also wrap it around the earlobe to try to use it in that application. Now, another thing that causes that noise artifact, that real choppy signal, is electrical interference, and this is common in the OR. Consider the amount of electrical tools and devices that are in an OR. Again, all of those will be shielded to try to protect this issue, but you have multiple opportunities for electrical interference. So your answer to correcting this problem is you need to try to move the pulse ox sensor as far away from the electrical interference as you can. And in the OR, there's so many devices. If you happen to get interference whenever a doctor is running a particular tool, try to get away from that tool as your answer to this, or just understand your dad is going to be wrong during that period of time, and when he stops the tool, things can return back to normal. So we talked about motion. The motion results in an inaccurate data based on the severity of the motion. So if you talk about shivers or tremors, they more than likely will have little or no effect. Now, the more extreme the motion is, pulse ox can read low, or it potentially reads hypoxia when the patient is not actually hypoxic. So a solution to this is correct this artifact by moving the sensor to the ear, the nares, or the forehead sensor. Now, other manufacturers, there's at least one that I'm aware of, that they actually take this photoplethysmography technique that we're talking about, and then they apply algorithms to that data to correct for motion artifact. So they're taking a troublesome situation, whether it be patient thrashing in bed or a patient you're trying to monitor on a pulse ox as you walk down the hall, and they're trying to correct that so you get a true number. So this is the enhanced versions of a pulse ox. So with poor perfusion, you end up with a situation where we just don't have a good exchange of blood coming to that site. You're going to end up with a low saturation. In low perfusion, the color difference between the oxygenated and the deoxygenated hemoglobin is so small, the pulse ox saturations can and could be inaccurate. So again, you correct this artifact by moving to another site. Again, preferably you're going to move to the ear, the nares, or the forehead. Now, poor perfusion is another area where manufacturers are going to apply an algorithm to correct for that artifact. So nurses in the audience might at times give dyes to a patient, ethylene blue, for example, and these can cause low saturations due to the peculiar light absorption characteristics that the dye causes. Now, the good part of this is you're giving the dye, and now that can affect the pulse ox. So you know that there's going to be a period of time that these numbers may change. And those changes are going to be transitory and are corrected as the dye dilutes throughout the vasculature and also by liver secretion of those dyes. So the problem is going to go away. So the biggest thing about this is understand I've given dye, it's going to affect my pulse ox. Now, nail polish and artificial nails have always been an issue throughout the time we've had pulse oximetry. There's conflicting data on this issue and whether the products and colors alter the pulse ox to a degree. However, it's generally believed that the saturation can be decreased by about 3 to 6%. It's going to depend on the actual color or the thickness of the product. First step, remove the nail polish or the artificial nail. Or you can move to another site. Again, the ears, the nose, or the forehead. Now, some people will talk about this sensor and they'll say, well, let's just turn it sideways. Instead of shooting it from the finger top down through the finger, well, let's turn it on the side and shoot across the finger. Your issue with that is you may get good data. That is technically then what you're going to kind of call off-label use, because you're not using it as the manufacturer has instructed you to do it. And so that comes back to the point that let's say you have a negative outcome because you decide to run it sideways. I haven't seen a court case involved anything like this, but if it would, that actually just gives the manufacturer an out at that point. We say to put it on the top of your finger, shoot it down through the finger, you turned it sideways. That's not how we say to do it. It's now going to be the hospital and the clinician's problem. If you were looking at normal data, it turns out was actually hypoxic. And skin pigmentation causes abnormalities as well. So this causes a diffusion of the light and results in a higher saturation than is actually present. So we may be hypoxic and we don't think they are. And the darker the pigmentation, the greater the variance from actual it can be. So there is research being done to correct this, and it's a calibration issue, trying to calibrate the pulse ox sensors to the different skin pigmentations. But as it stands right now, we don't have any device that is giving us a correction factor for this. I mentioned earlier that pulse oximetry measures oxygen. Well, many of you probably know that pulse oximetry doesn't do that. What it's measuring is saturated hemoglobin, not only oxygenated hemoglobin. So when we want to compare and look at a pulse ox number, you need to know the amount of oxygenated hemoglobin in the blood. You got to know the amount of carboxyhemoglobin in the blood and the metabolic hemoglobin in the blood. That's what your pulse ox is measuring. So if you want to compare it to the blood gas, you've got to order all those tests, add those numbers up, then compare it to the pulse ox, and that should be plus or minus 2%. Now, there is actually, if you're going to be doing anything with research, there is a more complex formula that you should put in all the data from the blood gas, and it actually fine-tunes that number to a more accurate number. Now, as one of the manufacturers, educators, told me in a conversation we were having in a clinical setting, you don't need to do that. You're close enough. You just simply add the SaO2, the metabolic hemoglobin, the carboxyhemoglobin together, compare it to your pulse ox number. So now we have a few poll questions. So I'm going to turn this back over to Monica, who will start the poll.
Thank you. Thank you so much. We do have a few poll questions that will be coming up. I ask that you are not in full screen mode so that you can see the polls appearing on the right side of your screen and participate in them. So I'll start with the first poll, and it reads, a patient arrives from a fire. What is the SpO2? So we have three answers that please choose one of them. It's 70%, 90%, or 100%. So once again, here's the polling question. A patient arrives from a fire. What is the SpO2? 70%, 90%, or 100%? So we'll pause for just a moment while we accept your answers, and we certainly appreciate your participation. And many of you are answering quickly, and I certainly appreciate that. And I'll leave it up for just a few more minutes again. When a patient arrives from a fire, what is the SpO2? 70%, 90%, or 100%? And we're going to go ahead and close out the polls pretty quickly here. And then I will post those results on your site so you can certainly see them. So I will turn it back to our speaker so he can address the answers. Thank you so much.
All right, thank you, Monica. So with our answers, we have 62% saying that the answer is 100%. We have 17 at 90 and 21% at the 70. And well, actually, your correct answer, the majority of you got it correct at 100%. One of the interesting things about the human body is that in the presence of oxygen and carbon monoxide, it has a 7 times greater affinity for carbon monoxide than it does for oxygen. So in a case of a patient who comes in from a fire, they're going to have usually a nice cherry red face. Put the pulse ox on them, you're going to get that 100% saturation. When you draw blood gas, you're going to find that their carboxyhemoglobin is going to be much higher. So let's say that particular number happens to be 30%. So now we have 100% saturation on the pulse ox, but we got carboxyhemoglobin at 30%, maybe 1% metabolic hemoglobin. So that means we have a saturation of oxygen in the blood, 69%. That means that patient needs to be heading to a hyperbaric chamber right now. They're in trouble, they need to be fixed. But the pulse ox doesn't know the difference in a situation like that. This. We can be deceived if we don't understand this abnormality about pulse oximetry. So we can move on.
Thank you. Our next poll should appear on your screen, on the right-hand side of your screen. And again, make sure you're not in full screen mode in order to participate. And it reads, a chronic smoker arrives in your ED. What is the carboxyhemoglobin? Is it 1%, is it 5%, or is it 12%? So I'll go ahead and leave that poll up for just a few more moments. Again, a chronic smoker arrives in your ED. What is the carboxyhemoglobin? 1%, 5%, or 12%? Answers are streaming in, and we certainly appreciate your participation. And we'll pause for just another moment while these answers come in. Okay, and I will go ahead and finish the poll out. And I will turn it over to our speaker to discuss these answers. Thank you.
All right, so our second question is about the smoker. And we have like 1% at 5%, 45 answers, I'm sorry, with 1%, 47% at 5%, 48% at 12%. Actually, you're kind of pretty close on that on number 2 and number 3, but the answer is typically number 2. Typically about 5 to 6% can be seen in smokers who smoke fairly heavily. So if we think about that detail, that's a nice little component of our normal range. What's our normal range for saturations? It's 89 to 100. We got a chronic smoker, 5% could be gone, carboxyhemoglobin. Let's move on to question number 3.
Okay, question number 3. Question number 3 reads, If the patient has disease process that increases metabolic hemoglobin, what is likely SpO2? Is it 99%, 90%, or 85%? Once again, if the patient has disease process that increases metabolic hemoglobin, what is the likely SpO2? 99%? 99% is the first one, 90% is the second one, and 85% is the third choice. So again, we'll pause just a moment. We have many people on the line, and we certainly appreciate your participation. Make sure you're out of full screen mode in order to participate. And we're going to go ahead and finish up the poll. And thank you for your answers. Okay, we have finished up the poll, and our results are, we have 44% of you say 90%. We have 37% of you saying 99%. And then we have 19% of you saying 85%. So I'll turn it back to our speaker to address those answers. Thank you.
Thank you, Monica. Appreciate it. Actually, your answer, if you think about somebody who has sickle cell anemia, chronically, when patients have metabolic hemoglobin, they'll actually be in the 85% range, which is interesting that you can see patients that live at these low saturations because of the disease. Typically, they're going to be on the lower side and in the 80s, and usually around the mid 80s is what you're going to see for these patients. So let's continue on now. Let's take a look at a blood gas study and a pulse ox data on a case study. So we've got a 68-year-old female. She's admitted for respiratory failure. She has a 2 liter per minute nasal cannula on. She is not COVID-19 positive in this case, but she's a former smoker. She has a finger sensor that is reading 98%. An ABG is drawn to evaluate the pH, and it reveals that the sum of the oxygenated hemoglobin, the carboxyhemoglobin, and the metabolic hemoglobin come out to 95.4%. So now that varies from the pulse ox reading of 98% by 2.6%. So that's greater than 2. And the way we are in medicine, if it's to be plus or minus 2, well, then the answer is it's to be plus or minus 2. So we have a variance here. So it's not within the normal range. But we would look at that number of 95.4 and we're going to say, well, we're still okay. Our patient's not hypoxic. But let's look at the breakdown. Our patient's pH is okay. Their CO2 67, PO2 is 27, and the SaO2 is 87. That's 1.8, a little bit elevated, but not too much. But look at that carboxyhemoglobin. That's coming in at 6.6. So now when we have a pulse ox telling us 98, patient's okay. We did a blood gas and didn't necessarily look at the breakdown of all the constituents, and we added them up and we said 95, our patient's okay. But when we take the time to actually look at those numbers and say, wait a second, the SaO2 is 87%, your patient's actually sitting in front of you on 2-liter nasal cannula and she's actually hypoxic. What else does this tell you? It tells you with a CO2, or carboxyhemoglobin, that actually should be a CO, of 6.6 on the blood gas, this is not a former smoker. She's telling you what she wants you to hear, but the reality is this is still an active smoker. So let's talk about sensor sites and options. So the finger sensor, that is our go-to sensor. It's a convenient site for stable patients. There's multiple different types of sensors, both disposable and non-disposable, that you can use. So the answer is going to depend on what your hospital wants to purchase, whether they want to deal with one or the other. Our institution uses mostly non-disposables. Uses mostly disposables. In other applications, we use the non-disposables. Now, the one thing about using, if you look at that top sensor on the finger there, that has a Band-Aid wrap on it, the big thing about that type of sensor is you need to make sure that the sending unit, red light, the manufacturer will tell you that's supposed to be on the top of your finger. The sun is supposed to be up, shining down through your finger, just like it's shining down on Earth, and the receiver is supposed to be on the bottom. And you need to line those up directly across from one another. So on a sensor like this, that is not a one-piece unit like the bottom unit, you have to take care of that. And I have had a pulse ox manufacturer tell me that, that the reason we got a bad signal was because the sender and the receiver were off by a millimeter. Just got to be like perfect. And not what we've ever been 100% of the time in healthcare, right? But never spent that much time lining up a pulse ox sensor. But that's what they tell you got to do, is line those up. And obviously you're going to get your best reading that way. Now, another thing you want to do, especially if you're using a sensor like this, is you want to make sure that that cable, the white cable, does not hang from the patient's hand. So we use a sensor like the top one. And what we do with that particular one, now ours happens to have the white cable is connected onto the receiver, so it ends up on the bottom of your finger. So we take that and we run that white cable back the finger and back by the knuckle. These have replacement wraps, so you can reuse this sensor for 2 weeks. We put another wrap around their finger loosely. Don't cut off the blood to their finger, and wrap it around the finger back there so that it supports it. So the way that cable doesn't want to pull that sensor away from the patient's finger. Now, if you're lucky, you also have a name band on that hand, and you can run that cable through that name band to help secure that cable as well. Now, this one shows it, on the index finger. My choice is that, and of course, this is the teachings of our institution, put it on the non-dominant hand. Obviously, if you're going to put a pulse ox on a hand they're going to use all the time, it's going to create issues for you. So put it on the non-dominant hand, but put it on the middle or the ring finger. Because even on the non-dominant hand, if they're going to use that hand, they're going to use those 2 fingers. So let's move away from those. Also what they call a butterfly wrap in the disposable, which when it's laying there in the packaging, it looks like the shape of butterfly wings. Wraps around the top of your finger, wraps around the bottom of your finger. Just again, make sure you line those lights up so they go straight out the top and down the bottom. Now, if you look at the non-disposable one at the bottom, you can see the gray plastic case on that. If you look where the finger would go into it, so if you're coming from the left side of your screen into that sensor and put your finger into that sensor, you'll notice that when it opens up, there's some white foam in there. That's the light shielding that we talk about to try to prevent room light from getting to that sensor. So that's built into that sensor. So those are some options for the finger sensors. Again, it's a good choice. Stable, healthy patients, it's a good place to go. Now, whenever we have issues with perfusion and movement, then we want to move to spots on the patient's head. So we may go to the ear sensor. So that comes in a couple different models. This sensor will clip onto the ear. There's also a concha model that will actually go into the ear and clip onto the back of your ear. So it's not going into the ear canal, but it's actually just going inside your ear. And it will clip onto that area and give you an oxygen saturation. So good for the low perfusion motion type of issues. One thing you got to remember about anything that's like a clip model like this, if I pinch your earlobe long enough, I may squeeze the blood out, you get bad data, and so we pop it off the ear and we move it to the other side, and now the perfusion will come back to the ear that we just left, and we can go on to the other side and collect good data. So we always have to be concerned about that issue about how tight these are for our patients. You can move to the nasal probe. So with the nasal, same issues. You're moving it to the head because of motion, low perfusion type of situations. But in this one, you'll notice that it clips onto the nose back by their face. You drape it up around their ear, so you take that support off. With a device like this, you generally have a clip on the cable that you can clip onto the patient's garment. So a big, heavy cable is not going to be pulling at the sensor. Another advantage to this one, though, is the fact that this has been shown to decrease pressure injuries compared to the forehead sensors. A good option to go with this particular brand of pulse ox sensor. Good device to move to. This one shows the forehead model. So in this particular application, it has the same reasons why we move here. As perfusion and motion, you should place this sensor above the pupil of the eye. And then these sensors have replacement adhesive on it. So you can keep either pulling off a strip and there's a new fresh one underneath, or in other cases, they give you a new adhesive to put onto that forehead sensor and you can stick it onto their forehead. But they don't always stick that well at times because of, a diaphoretic patient or oily skin. So that headband comes in handy, but that headband is also something you have to think about. I take that headband and I pull that around their head tightly. I then drive that sensor into their skin and I can cause a wound with it. So I can cause pressure injuries with it. You also squeeze the blood out of that area and give yourself bad reading data as well. Again, if you see the white cable coming down, drape that over their ear. It helps to take the weight off, and you should have that clip you can clip onto their gown. Now, if you're working in an ICU and you have a patient who's on a ventilator and they have a endo tube in and you've got a tube holder in place, there are some tube holders that actually have a strap that goes around the patient's forehead. Do not place this forehead sensor underneath that because we generally make that strap pretty tight, help hold in that endo tube. And if you put the pulse ox sensor underneath it, you're going to create a wound. So you don't want to do that. Now, the other thing you need to do, specifically emphasized on the forehead sensor, is you need to move it on a regular basis so that you don't create the pressure wound that you can get. These sensors, if you look at them real close, have to send the light out at a 45-degree angle. So they usually have a little bubble in there, hard clear plastic that's sending light out and then being picked up by a receiver. And those little hard bubbles can actually cause wounds. So our institution says that you got to check it every 12 and you got to move it every 24. That's our policy. My policy is if I'm going to take it off, I might as well move it while I have it off. If I'm going to check the site, I might as well just move it to the other side while I'm at it. So I just move everybody Q12. Do what your hospital says, but if you're having an issue with wounds, move those more frequently and you'll take care of that issue. Let's talk about troubleshooting. Let's figure out how, when we have a problem, how do we correct it? We looked at those abnormal signals before, so let's talk about what we can do to make sure that we correct these issues. So if we have a patient who has low perfusion, well, that's typically going to be a patient that has a finger sensor on. As they are critically ill, they start to vasoconstrict and shunt blood to the core, and we're going to get low perfusion in the extremity. Let's say this patient has a bad heart, and they're not, if you put cardiac output, you're not going to perfuse that finger. So we need to move back to the core to try to get a signal. So you're going to move to the ear, the nose, or the forehead to reestablish a good signal. If you have electrical interference, remember the idea with that is, you've got to try and get away from the electrical activity. So most likely that's an OR problem. Or you can shield the light if it's a light issue. It's creating that noise artifact and that 50, 60 cycle interference that you're talking about. And what about motion? So you need to consider a site change. Let's say the patient is constantly moving their hands. Then you're going to have a lot of bad data. If your patient is grabbing on and holding on to things, maybe they've just wakened up on a mechanical ventilator and they're trying to grab and pull things out. Strained, they're grabbing onto the bed rails. Well, if you're grabbing onto the bed rails, you're going to squeeze the blood out of your fingers, and we're going to have problems with that type of issue. So move to another site, move to the forehead, move to the ears or the nair. Now, what if you have a patient who has it on the forehead and they're anxious and distressed? But when you notice that they're not moving, you get a good signal. But when they start moving all over the place again, now you get hypoxic data showing up. There's times when you need to consider maybe we should discontinue the monitor. They're constantly thrashing. If they're not going to get some sedation to calm them down, then it's probably a good idea to move that, but discontinue that monitor. So, again with troubleshooting, you have a number that we see as hypoxic, we look down, make sure you got the good waveform. If you don't have the good waveform, troubleshoot those issues. And again, remember we talked about heart rate, pulse ox correlation. You need to make sure that there isn't a big difference between them. If you got a big difference, the pulse ox is giving you bad data in that site. You got to move to another site, or you may not have an option at all. You may need to consider, doing that monitor. So I talked earlier and said photoplethysmography works by looking at color. Well, you can do the exact same thing. You happen to be in an ICU and you have an art line, see saturations, kind of thinks maybe something's good, maybe this is a questionable signal. Grab a hold of that art line, pull back on the art line and draw some blood in and look at the color. Be your own pulse ox. If it comes back nice and red, you're okay. If it's dark, yep, you definitely have bad data. A week ago, I had some students in an OR, very rare procedure. I happened to be talking to the students because I said, if you look at the monitor, this patient's saturating at 82 to 85%. We got plenty of opportunity to fix this patient if there's an issue. And I said, if you look at the waveform, that's a really nice waveform. You've got a really good heart rate correlation. It's like, this doesn't tell me that that's wrong. That tells me that I have a good signal that's numbering 82 to 85. And at that point, I happened to just notice that the anesthesia fellow pulls back on the art line and looks at the color, nice and red, not a problem. Now he goes and continues to pull a gas, send it, and obviously it wasn't a problem. That's one of the odd things. It's non-invasive technology. I don't know what was causing a perfectly good-looking waveform with a heart rate correlation to say that that number was wrong, but it was wrong. So that's why we need to do things like get a pulse ox correlation. So if you're going to do an ABG for some reason, do a correlation with the pulse ox. When the blood flashes into the syringe, that's when you want to look at the monitor and record that SaO2. Then order your blood gas with an SaO2 met and carboxyhemoglobin, add the 3M up, check to see if it's plus or minus 2%. Now, before I tell you to just go arbitrarily ordering metabolic hemoglobins and carboxyhemoglobins, some ABGs automatically come with an SaO2, others don't. But in our hospital, respiratory therapy has a protocol that allows us, we get a blood gas, we can get an SaO2, a methemoglobin, a carboxyhemoglobin, and check the pulse ox. It needs to be plus or minus 2%. So if the SpO2 is 86%, the saturation is 94%, if we've exhausted all of our troubleshooting options, should we continue to monitor when we know we have bad data on the screen? Fact is, I have seen this issue in real life, and potentially you can do harm to a patient. You got a patient with an 85 and the blood gas is 94. Should we leave that 85 on the monitor? Are we going to trust that everybody's going to give them a report and say, hey, the pulse ox is off by 9%, it's reading low? And is everybody on the team, the med student, the intern, the resident, the fellow, is everybody on board that the pulse ox is wrong? And remember, we need to add about 9 to that. But you know what happens when you do pulse ox correlations? You find that this time it's off by 9, another time it might be off by 6. So you're aiming at a moving target when you're doing that. So interventions that can be done to fix low saturations can cause harm, and we should first do no harm. Should I do lung recruitment, which could potentially cause a pneumo? Should I do a bronchoscopy, puncture the lung that way? These interventions are not necessary. And the thing is, there's times when you're going to like pull gas and like, wait, where did this come out of left field here that we actually don't have reliable data? My opinion is there's times, it's a small percentage of time. I mean, we're talking probably less than 1% of the time that you should shut it off, but you should shut it off at times. That's my belief. So finger sensors on the forehead. It used to be a thing. I don't see it like in our institutions, but it pretty much was a common thing in the past. But this study looked at 20 hypoxic patients who were evaluated in ED. No patient contained an SpO2 with a finger sensor. So they just moved the finger sensor to the forehead. 11 of 20 patients had an absolute difference that was greater than 5%. Key takeaway, use the right sensor for where it's intended to be used. Talk about oxygen real quick and we're about done. Quicker when the slides move fast on me. In the COVID era by the CDC, you're shooting for oxygen percentages of 92 to 96%. In mechanical ventilation, general rule of thumb is keep it less than 96%. There is data that says patients are kept on a mechanical ventilator with saturations 97% and above. At 6 months, 9% more people are going to be dead with the high saturations. We can conclusively decide why that is, so there's more research being done on that, but the rule of thumb is turn down the O2. Should we indiscriminately apply oxygen to all patients? When a pulse ox is used to monitor respiratory distress and saturations are normal, desaturation is a warning sign of decompensation. So don't mask it by routinely providing oxygen. When we give oxygen routinely, it does little to alleviate their difficulty in breathing and effectively mask deteriorations which would have been seen in the falling oxygen saturation. Studies have looked at thousands of non-hypoxic MI and stroke patients, and the one that they found by looking at 2,000 in the MI study and 8,000 in the stroke study is if people were not hypoxic, 6 months, there was absolutely no difference in mortality. So why give a drug that they don't need? The other thing about that is the more oxygen we give, the less nitrogen they get. We're breathing 21% room air, 78% nitrogen, 1% of trace elements approximately. What does nitrogen do when it goes to our lungs? Well, it doesn't go to our blood, so it stays in the lungs and it keeps our alveoli from collapsing. So there's a thing called nitrogen washout. As we wash out the nitrogen, we collapse the lungs. Just make, in the respiratory world, you just make more work for yourself by having a patient on a high saturation. So key summary points. Pulse oximetry is a valuable tool with a high degree of proficiency. Keep in mind, there are limitations. It's a smaller percentage of the time. With non-invasive technology during critical illness with poor perfusion or motion, you can have issues. So remember the troubleshooting techniques that we talked about. It will allow you to continue this technology or bring you to the realization that you should consider discontinuing pulse oximetry monitoring. Also, when you're drawing a blood gas, perform a correlation to confirm the monitored data or consider discontinuing the pulse oximeter. So I'd like to thank you for your time. I appreciate everything you've done today. I'd now like to turn this back over to Dr. George, who's going to tell you how to get your CEUs. Very much.
Thank you, Greg, for that thoughtful and timely presentation. At this time, I would like to remind you how you can obtain your CEUs. This educational activity is approved for 1 contact hour for nurses, respiratory therapists, and EMS professionals. Nurses and respiratory therapists. To obtain CE credit, go to www.saxtesting.com/BO. For EMS professionals, to obtain CEUs, go to www.saxtesting.com/CMS. You will need to register at the site. You will need to complete the evaluation, and upon successful completion, nurses and respiratory therapists will be able to print their certificate for completion. For EMS professionals, your certificate will be emailed to you. Support for this educational activity was provided by Philips. Archive on-demand version is available. It is available at better-outcomes.org. Email will be sent to all registrants when it is available. The on-demand version will be accredited for nurses and respiratory therapists. So at this time, I'd like to address some of our questions. We thank you for the questions. We'll try to get to as many as we can. One of the first questions that we had, Greg, was from Monica that said, what are the implications for maintaining pulse ox with PPE requirements?
So really the thing about the PPE requirements is you need to, in the COVID era, is you need to first protect yourself. So that's what we've done. So with maintaining pulse oximetry, you can go ahead and put that on in the patient as you normally would, but you just got to remember that you got to be PPE protected when you go into those rooms to protect yourself. So it's not going to have any negative effect on pulse oximetry. We do want to have at times PPE on the patient, covers the nose and the mouth, but it won't affect the, the nasal sensor, won't affect the ear sensors when they have a mask on as they are required at some institutions. So PPE will have no effect on what we do for our patients. So protect yourself though. Next, Betsy.
The next question, there were many questions, and I'll try to summarize those that relate to the placement of the sensor. And one question was, can you use the finger pulse ox on the ear, toe, etc.? Or do you need to use specific ear probes, forehead probes, etc.?
So your answer to that is you need to use the right probe for the right portion of the body. If you think about the finger sensor is, like probably a half-inch thick. So if I take that down to the ear, where we're now talking about a much narrower surface that we're shooting it through, that device was calibrated based on the degree of anatomy that it was supposed to be going through. So you should use the right sensor for the right portion of the body. And again, the issue would be, I do work on the side, from an expert witness side of things, and if you use a wrong sensor on a wrong portion of the body, and let's say that you end up getting data that says they're 98% saturated, when in reality they're 85% saturated, the negative outcome happens to that person, you potentially could have a situation where you could have a lawsuit because of, an anoxic brain injury. And in that type of situation, as soon as the pulse ox manufacturer figures out you put a finger on an ear, they're going to be like, that gives enough doubt that you did it wrong as a hospital employee. And pulse ox manufacturers drifting out of the case because they're going to come after the hospital and the clinicians. As soon as anytime a manufacturer, they put it out and say to use it this way, you need good solid research to prove you should use it in a different manner. That research doesn't exist. It's just always use the right. If they make an ear sensor, that's what it should be. I've been around this field long enough. I can remember fingers on ears and fingers on foreheads. But when you look at blood gases, sometimes they're right, other times they aren't. And so your best interest is use the right sensor for the right portion of the body.
So we're running out of time. I know everyone had great questions, but maybe for our last question, Greg, do you have any recommendations on how long you can use a disposable finger sensor on the finger before changing out the site?
So it actually should tell you in your packaging what it is, but as a rule, you'll generally see it's like 14 days. Now that's well, let me back up here. So if you're talking about, like, say, the butterfly sensor, that one goes onto the finger and sticks in place. That has a shorter time frame. I want to say that, like, the one I'm familiar with was 7 days. Now, if you talk about the wrap that I showed you in these slides, that one's 14 days, but you have replacement wraps on it that you use to put it on to regain your adhesive. So with the butterfly style, I had a patient a week ago or so that had one of those on, and it just kept sliding off her finger, and the alarm would pulse ox would alarm low saturations, and basically go push it back on. Obviously, I replaced the pulse ox on her. And of course, it turns out she just keeps picking it off. And she would move it amongst her fingers. So she was stable enough. This is the time when we can lose it because she's not going to allow it to remain in place. But if you actually check your manufacturer literature it comes with, or look up at the manufacturer site, it'll tell you the days it's supposed to be. Truth be told, they work longer than they say. Some products are made to be exchanged at a certain time frame for a particular reason. Other times manufacturers may want to change quicker. It does sell more product. So I'm not saying that's what they're out to do, but there are things that in other applications, not pulse oxes, where things have a recommendation to do daily, and there's no real good reason for that, other than it does provide more product purchases. So go back and look at the manufacturer's data. You're welcome.
Thank you, Greg, and thank you everyone for your insightful questions. We've run out of time, and I'm going to turn the program back over to Monica for some concluding remarks.
Thank you. Thank you so much. Thank you for your expertise. And this does conclude our webinar for today. I'd like to remind the audience that there is a survey for you at the conclusion that would pop up immediately, and we would greatly appreciate you sharing your opinions on today's webinar. We thank you again on behalf of our presenters, Sachs Healthcare Communications, and our sponsor, Philips. I hope you enjoy the rest of your day.